on the topic of new medications. And I'll stay with you, Dr. Luniova, as we talk about some of the new medicines that are out there and available. I guess, specifically, how do you see these having an impact on your patients?
Well, it is a great challenge to bring any medication into pediatric world. Children are much more and stricter regulated when it comes to research in the pediatric world. There are a lot of barriers to complete those enormous projects that are very expensive and very few can carry on for multiple reasons. And every time when we have a new medication that comes into the adult world, the clinical, once it's in the clinical world, we start looking at adoption or repackaging, if you will, of those medications, trying to bring it into the pediatric side. But I am very happy to see that more and more medications are coming out specifically targeting pediatric population. And in the recent years, one of them was, and I'm not remembering a name, I apologize. It will come to me. One of the few medications that came on the market in the last decade probably is CBD or Epidiolex, that is targeting particular group of patients with epilepsy that have Lennox-Gastaut syndrome. It helps controlling and decreasing seizures in those patients that many medications fail to do so. And I'm also happy to say that some manufacturers are thinking about formulation of medications for children. That is another challenge that we struggle with, is to make medications accessible to children that do not take tablets, do not swallow pills or capsules that are enormous size, sometimes even for adults. And anytime we have liquid medicine in the market, we get really, really excited. So one of those two medications came out very recently was topiramate and zonisamide. And on very good authority, I can say that zonisamide tastes really good.
The challenges with the youngest patients are immense, obviously. Yes. Dr. Patra, we know that anti-seizure medications are the first line of treatment for anyone with epilepsy, but unfortunately some are drug resistant. That's a challenge in itself. And under what conditions would you begin an evaluation to see if a patient is a good candidate for epilepsy surgery?
Yeah, so just so people who have failed at least 2 different medications, and by failure meaning is that they continue to have disabling seizures. So sometimes seizures can be quite mild and patients don't lose consciousness. And the drugs will limit the disabling seizures. That's not really the patients who are great candidates for surgery. We look for patients who are, really significantly affected by the disease, where those seizures are disabling for them and affecting their quality of life. And it's not really, you have to have, 5 seizures a month or 10 seizures, a month. It's more about how disabling are those seizures for that individual. So for some people, having one generalized seizure every year, that's significantly disabling, and it affects their lifestyle and their ability to socially interact. Others are having multiple, 50 or 100 seizures a day. So, the spectrum is quite broad, but anytime patients start to fail 2 or 3 medications, those are patients we start considering for epilepsy surgery. Now, historically, it was only certain types of epilepsies that were really, better candidates for surgery. But over the past 10 years, as the restorative therapies have kind of taken a hold and more research has come out and more innovation has entered the field, the types of epilepsy you can treat now with surgery is really starting to broaden out. And epilepsies that were, even 5 years ago considered non-surgical now can at least have a partial surgical solution where we can, maybe we don't completely cure the epilepsy, but we can significantly reduce the amount of disabling seizures, and in some cases, turn disabling seizures into aware seizures where, patients may be having, still maybe, let's say, daily seizures, but now, they're not losing consciousness during those events. So these are things that have been, the innovation has really been significant over the past 5 to 10 years. And in fact, I think it's going to accelerate even more in the next decade.
That's encouraging. And Dr. Luniova, let's talk about genetics a little bit. This has been a growing field, obviously, and particularly in the area of pediatric epilepsy. Have genetic panels help patients and families cope and learn a little bit more about their diagnosis and some of the impacted treatments?
Well, genetic disorders, just like any others, affect patients in many different ways. But genetic problems, they affect entire family. And knowledge of specific diagnosis allows families to take steps in planning for future children, assessing risk for the same problem to happen in the future. They can anticipate, if known problems could be anticipated, then it helps in surveillance and building the treatment team that allows early recognition of problems. And for that reason, genetic testing and genetic team became a staple in our clinic, and we always consider that approach. Not only does it give an answer to family that there is a name for their diagnosis, there is a name for their problem. It also allows us to choose treatment that we know will work the best, as we may have seen in the same patients that had the same experience and had success. And it allows us making choices for diverting treatment plan in a different directions much earlier with greater success for treatment and greater outcomes down the line. And in the world of genetics, a lot of changes happening in the last decade. The number of genes that implicated in the diagnosis of epilepsy increased exponentially. We started doing panels with only maybe 25, 27 genes on the panel less than 10 years ago. Today, we have more than 300 genes on that panel, and it's only those that were already confirmed through different ways and avenues that they are truly related to epilepsy and cause epilepsy as a main core problem, or sometimes the only problem. But there are other more than 2,000 genes that are either candidates or being reviewed for being candidates, or they are part of other syndromes that may be included in different panels, but also associated with epilepsy as part of their diagnosis. So I'm very optimistic that we will continue enjoying the benefit of this technology, and more gene candidates will be identified, and more conditions, more patients with epilepsy will have treatment that will work for them.
Dr. Patra, I want to double back a little bit when we're talking about surgeries. Specifically, resective surgery, and how do you determine how much brain tissue to remove? And a newer procedure, talk a little bit, if you could, too, about laser ablation.
Yeah. So the historical treatments for epilepsy have been the so-called resective surgeries. And the answer, it depends. So the most common resective surgery is for temporal lobe epilepsy. And it's particularly an area of the temporal lobe, kind of deep in the temporal lobe, that's important for memory function. And that area, unfortunately, can become epileptogenic and start generating seizure activities. There's a various of risk factors that can predispose one to that. So when we treat that, we basically remove an area about the size of half your pinky finger. And that's what's typically removed for a mesial temporal lobe resection. Now, there's another surgery called a standard temporal lobectomy. So if the seizures are coming from that deep area of the temporal lobe, but also some of the outer portion of the temporal lobe, then you end up removing a larger portion of the temporal lobe and doing what's called a more standard temporal lobectomy. Obviously, we would only do this if the memory function is already significantly compromised from the epilepsy. If somebody still has very good memory function, then we definitely don't want to do a procedure that's going to significantly worsen that and worsen their quality of life. So there's not a huge amount of patients who would qualify for that. Now, the laser ablation treats that same area, the size of about half the size of your pinky, through a very small 2.5 millimeter incision. Okay, and through that incision, we place a fiber optic probe in that structure. We then take the patient in the MRI scanner, okay, and we heat the tip of that probe up. And you can visualize the temperature in the brain while you're heating up the tip of that probe. We know that once the temperature hits a certain level, that area of the brain is permanently disrupted. And you can get very good margins, about 1 millimeter transition from the area you want to kind of destroy, right? That's causing the seizures, and in the area you want to preserve. So, so that procedure, it's also abbreviated LIT, laser interstitial therapy, has gained more and more popularity over the past 10 years, where if somebody is a candidate for the resection, I always discuss the option of the LIT procedure. So what are the advantages of the LIT procedure? It's generally a lower risk procedure, okay? Less of a scar. You know, when you have a larger surgery, you have a bigger scar, and there could be some cosmetic issues in certain types of patients that develop as a result of the surgery. The LIT kind of eliminates that. You know, it's still not without complication, but the complication rates are lower, especially the cognitive complications that can come with a larger temporal lobe removal. So that's the advantage of the LIT procedure for those patients. The cure rate from LIT is around 60%, okay, based on the studies. The cure rate for a temporal lobectomy is probably closer to 70%. So the LIT is much less invasive, but you have a little less chance of seizure freedom because you're not destroying as much of an area, right? It's less invasive, but the side effects are lower. So I always present that to my patients because we really want to tailor treatment that's best for that patient in particular. So I think a lot of patients now are kind of gravitating towards a LIT because you can have a LIT, and let's say you're in that 40% who don't become seizure free. You can always do the temporal lobectomy at a later time, right? Because once you have the temporal lobectomy, it's done. Or you can also do other restorative therapies, right? So, but I think the overall shift is more and more LIT, less and less open surgical resections. And that's been my practice where, 10 years ago, we were doing almost all open surgical resections for that temporal lobe epilepsy. And now I would say it's more like 75% LIT, 25% open surgery.
And you got to believe that technology is only going to get better as time goes on too.
Yeah, I mean, that technology is getting better. There's actually some devices that are available now that, are used for different different disease processes right now where you can actually create that same temperature change in the brain without actually making an incision by using ultrasonic energy, where you don't have to make an incision at all, and you can kind of lesion an area of the brain that you want to kind of stop functioning, and you want to stop it to function because that's producing the seizures.
That's really
Right.
remarkable.
So
isn't it?
that's coming down the pipeline very soon. There's some technological issues right now that are preventing it from being robustly treated for, use in epilepsy. But I think that's just a programming issue that will be solved pretty soon.
That's exciting. Dr. Luniova, let's talk about rescue medications. Patients and families who are experiencing these prolonged seizures depend on this medicine. But talk a little bit about the challenges of delivering the medication in those circumstances.
Well, on one hand, we have enjoyed access to intranasal medication since about a year and a half ago, which was enormous step forward because until then, the mainstream was less convenient rectal gel, and that becomes a significant problem for children that are older than toddlers. But another barrier that I have observed over the years is parents or caregivers or teachers are scared to use the medications. Majority of prescriptions that go for the purpose of rescue medications in children consist of midazolam that can be in different brand, but right now the rescue medicine for midazolam, it's nasolam. And it does have its own little differences about how it's prescribed. It was designed to treat adult patients for a particular purpose, but we try to use it for children just like every other medication we try. And insurance companies a lot of times deny nasolam for age restrictions. So that's one of the barriers. However, if you do have that medicine, it is a great source to stop seizure at home that can potentially eliminate need to go to the emergency room. That's the ultimate goal for the family, not to have life disrupted when a child has a seizure. Obviously, the first goal is to stop the seizure to keep children safe. But another one is life needs to continue, go on without extra visits to emergency room and an extra financial burden on the family to pay for that visit. But again, a lot of times there is a fear of use of these medications, and I encourage you to go and speak with your providers about your concerns if you have them, and bring your caregivers with you for that conversation so they could be educated, they could relieve their anxiety about using these medications. The other great choice is diazepam. That is the old medicine that we have been using. Now it's just repackaged with intranasal form, which is way more convenient, and we're very happy to prescribe that. But again, a lot of insurance companies refuse to cover it, or they say they cover it, but the parents end up with a copay of $500, $600, which is not feasible. But as a medicine, it is safe. It has been studied extensively, and it is shown over and over and over again. It is effective to treat prolonged seizures out in the community, anywhere where patient and medicine are. And it is something that can effectively allow the same effect that midazolam can. Stop the seizure, keep you home, recovery at home, no extra trips, no minimal interruption to your family life. There are other medications that could be used as rescue medications that are not in the form of injectable medications, but they are in the form of either dissolvable tablets or wafers or liquids that could be administered through the G-tube or given as little drops that could be absorbed through the mouth, lining in the mouth. But those are more individualized, tailored individually to the patients for their particular and specific needs. And again, if you find that medications that you have in your backpack or in your cooler or in your car or anywhere that you keep your rescue medications, if they don't work for you, go to your doctors, talk to them about it, explore other options. It can be a great help in keeping you safe, keeping your loved ones safe who you take care of, who have epilepsy, and it can help you have life a little less disrupted.
You just touched on it. Sometimes you feel alone in this process, but you said
Absolutely.
there is support out there.
Absolutely.
Dr. Patra, let's talk a little bit about neuromodulation devices. We're talking about the nerve stimulators here, the VNS, the RNS, and DBS. Talk about that form of treatment and how it can be helpful for patients.
Yeah, absolutely. And this is an area I'm really passionate about, and I do research in. So please just interrupt me if I keep rambling on too long.
Fine.
Seriously. Yeah. So this is called neuromodulation, and these therapies have been around for 30 years at least now. Now, what's been around for that long is called the vagal nerve stimulator, and that's a device that's used to electrically stimulate the vagus nerve, which is a nerve in your neck. When you stimulate that nerve in the neck, it sends signals to your brain, and it adjusts neurotransmitter levels within the brain itself, and it can make the brain less likely to have a seizure. It's a fairly low risk therapy, well tolerated, and most, the average, the responder rate is around 50%, meaning about half the patients who have this device implanted have at least a 50% reduction in disabling seizures. So it's a very good therapy. It's been around for a long time, but there hasn't been a lot of new innovation in that device, with the exception of heart rate detection. So now the latest battery of the vagal nerve stimulator can detect changes in heart rate. So why would you want to do that? When you have seizures, most seizures, even before they start, can have a change or fluctuation in your heart rate. So by detecting that change in heart rate, you can program the device to fire based on that change in heart rate and hopefully deliver that stimulation right before the seizure is actually causing a clinical change where you lose awareness or something like that, so that you can intervene in that seizure earlier. So that is a significant improvement in that technology. Now, deep brain stimulation is a device, again, that's been around for 30 years, mostly to treat movement disorders. And those are Parkinson's disease and certain types of tremor. They did studies on this in the 2000s, and it's been FDA approved now to treat epilepsy. Now, in this device, the two electrodes are implanted in the brain, okay, not in a nerve in the neck. So you get a little more direct stimulation of those areas that could potentially affect the epilepsy network. So what's changed in the past 15 years as well is that we view epilepsy not as a disease of just one area of the brain that's abnormal. It's actually a network. So think of like a connection, a network connection, like a computer network, and there's these different hubs in that network, and that's how your brain, communicates and talks to each other, right, within that network. In epilepsy, there's these nodes that are, kind of hyperactive and can trigger seizures. So it's not necessarily just one area. So the deep brain stimulator is placed in an area that has the most likelihood to influence, a wide network, mostly what we call limbic epilepsy. And those are the epilepsies that we treat with those temporal lobe surgeries, okay? So the DBS is great as well. It's good for certain types of patients. it's either on or off. So it's not something that can adjust to anything, like the heart rate detection or an EEG. It's either on or off. So for that reason, the battery life, it may not be quite as long as some of the other devices. And you're really limited by the FDA to really treat one area of the brain with the DBS. The RNS device, which is called responsive neural stimulation, has been around kind of the least amount of time. It got approved, 7 or 8 years ago by the FDA. And in this device, you have 2 electrodes, but you can place them anywhere in the brain. Those electrodes are connected to a battery that has a built-in computer. And that battery can detect the EEG of the brain. And it's responsive because it can respond to the EEG in the brain and deliver stimulation only when needed. So this is kind of one of the first clinical applications of what's called the brain-computer interface. And I don't know if you guys follow the media, Neuralink with the Elon Musk company, it's a similar type of device, but this has been, developed many years ago by a company, and it's been clinically used. And in our practice, we've seen quite good results with this device, to the point where now probably 75% of our patients that we see who have any type of surgery will have this type of device. We've analyzed our data, which is very similar to the national data reported it tends to get better with time. So if you've had the device only in for like 6 months, the reduction in disabling seizures is only about 50%, which is still good, but once you get to a year, it's up to about 60%. Once you get to 3 years, it's up to 85% reduction in disabling seizures. So the interesting thing about this type of technology is that it gets better over time. Why is that? It could be because we're fine-tuning the programming. Okay, the epileptologist will keep adjusting the programming, adjusting the type of stimulation being delivered to try to stop that seizure network. And 2, it may be just the stimulation of the brain over months and years makes that brain less prone to producing seizures. The honest answer is we don't know for sure. It's an area of really active research. So there's huge potential with this type of responsive stimulation. And I think a lot of it will be driven by artificial intelligence algorithms that will ultimately be used to detect, the seizures and deliver the best possible combination of stimulation to stop the seizure. So even now with that company, they have, thousands of patient years of data stored. So basically now, if you have a very challenging patient, you can ask them to run a machine learning analysis on the patient's data. They'll cross-reference it with thousands of patient years of data, look for similar patterns. Okay, this type of, this epilepsy is this type of pattern, with these are, 100 other patients who've had this type of pattern, and this is the best stimulation that worked for this pattern. So this will just get better in time. We know that the AI is just surging right now, and the amount of growth in the area is going to help. I think it has tremendous potential to help our patients.
This is the good use of AI.
Yeah.
Dr. Luniova, I want to circle back. You mentioned earlier cannabis and some of the questions families have as a form of treatment. Obviously, there's probably still a taboo about cannabis, maybe not, but I'm just curious about the effectiveness and the availability and the options when it comes to that.
Well, as anything in our world, it does require specific criteria to be met to be prescribed. But I can assure you that we are not resistant to prescribed CBD. We have an FDA-approved product that has been tested. We use it when needed. And specifically, as I mentioned, the patients with LGS or Lennox-Gastaut syndrome, they seem to be the most sensitive to this medicine, and it is the most effective. However, it is not the medicine that should be, or I have ever seen working well, used alone. It is an adjunct medicine to other medications that patients use. It is effective. However, it's not 100% treatment for 100% seizures, even in patients with LGS. It will not be my first choice for most of the medication. For most of the epilepsies, for most of the patients. I have tried many different epilepsies, and I can tell you that it was not the greatest effect that I was hoping for, but I also have seen great and amazing effect in patients with LGS. Sometimes the benefit and seizure control are temporary. Sometimes it is sustained for a long period of time. Generally, it's a well-tolerated medicine. What I would like to warn everybody is if you want to try CBD, specifically for epilepsy, go to your neurologist. They can prescribe it. Going to dispensaries for CBD products is an option if you either don't have a diagnosis that needs to be on the paper or for some other reasons. But in that case, you should do some legwork and verify that it is a place that has followed standards in producing the product, coming up with the oil, the actual oil. If they have testing completed on their product, that would be ideal. Unfortunately, it's an expensive and cumbersome process, and not a lot of sellers out there can afford that process. But if it's possible, ask them, always ask. They may say no, but always ask if they have tested their product and what is the result of the testing and how much CBD is in there, how much is THC is in the product. Why is it important? For one, sometimes CBD contains, the CBD product that is labeled as CBD may contain rather high percentage of THC. For THC, it's a very different story in the world of epilepsy. While anecdotally in the media, you may have seen family or two that swears that they have cured their epilepsy by using THC. In its majority, and for majority of patients, it may actually provoke seizures, even in those who never had seizures. And I see it in adolescents over and over and over again. That's why you absolutely need to make sure there's no high THC content in the oil that you are getting out of dispensary. The other problem is how the plant was grown, what was used, how was it stored, what else is in there, how clean that product is, and obviously how much of that you need. And again, your doctor can help you with that, even if it is not prescribed Epidiolex. CBD is a CBD is a CBD. We have guidelines for dosing of the medicine. We can help you with what to do when you are getting your product somewhere else. But the content of that bottle that you're getting, the quality of that oil that you're getting and want to use should be reliable, verifiable, and so you actually get benefit for what you're looking for. There are other benefits for CBD that are outside of epilepsy, and but those are not dramatic for most of the people. Sometimes I hear they sleep better, they feel better, they're less anxious. For some, it's the opposite. They don't sleep, they have diarrhea, they have abdominal cramps. Just like any medicine that we use, it does come with side effects, and anybody can experience those. And if you start using that product, be sure to mention it to your doctors, because it does interact with other medications you take. That is something that your doctor needs to know, because adjustments could be made to avoid unnecessary side effects and difficulties that you may experience if you combine those. So the moral of the story, speak with your doctor.
Always have that conversation. It should be open. Dialogue
Absolutely.
with you.
And like I said, we maybe there was a stigma at some point in the past, but I don't think it was more for us looking down. It's more for us not being able to prescribe. We were prohibited from prescribing this product. Now we have FDA approved licensed product. We can prescribe. We have that authority. If you need it, if it's for you, we will offer it to you. If it works, great. But if it doesn't, don't be surprised. There are many like you.
It's another option that they have, but know the risks going
Yes,
in.
exactly.
I want to put this to both of you. Let's talk a little bit about some of the barriers to epilepsy care that you would like to see improve over time.
Yeah, I can start. Yeah, from a surgical side, I think it's awareness of that surgical options exist, and it's estimated that only like 1 in 20 patients who are surgical candidates actually get referred to a level 4 epilepsy center where they can really do a proper evaluation to see if that patient is a candidate for epilepsy surgery. So that's a massive amount of patients who just don't know. And different advocacy groups and the neurology societies and the neurosurgical societies have been working on this for decades now and barely made a dent. So I think that's a huge opportunity to provide that awareness, and how that's going to be done in the future, maybe through social media, maybe through the manufacturers of these devices. But that's something we all should kind of work on, and just making sure our friends and colleagues at least get referred to a level 4 center where they can get evaluated. Because I have patients who have treated in their 60s, who've had seizures, disabling seizures for 30, 40 years. And, some of them been cured, some of them, hardly have any seizures anymore. And they've had this whole life of not even being evaluated. So awareness is probably one of the biggest challenges right now.
I agree. Awareness is a huge deal, especially in treatment of children, because they grow up in the families who have mom and dad and grandparents and sometimes great-great-parents. And until they have a seizure, sometimes more than one, nobody talks about the fact that granddad had a seizure, or grandma had a seizure, or second cousin had a seizure. And once you say, oh, our child had a seizure, we were in the emergency room last night, you start hearing from multiple friends and relatives, oh yeah, we dealt with that last year. For generations, word of epilepsy was not good. It was coming with a bad stigma from medieval times, and it still lives in older generations' minds. Even today, people do not speak about epilepsy. They do not speak about seizures. They find it embarrassing. They find it hard to admit. But without support, you cannot be alone. You should not be alone in this process. And another challenge that we have for children that is more specifically to children is care for children with epilepsy at schools. A lot of schools, they either don't have great awareness again, or they don't have resources or personnel that is trained to care for a child who had a seizure, how to behave, what to do, how to attend, how to treat, how to store medications. A lot of schools do not have that process or policies or rules. And I strongly encourage you to reach out to your principals or school nurses. Have them call Epilepsy Foundation of Michigan. They have nurses that can educate, train, teach, and establish a process at that school that will allow the child to go to school without fear that what if something happens? What can we do? What will happen? Today, the go-to is anything happens, they call 911 and they take everybody to the emergency room, whether they should go there or not. And again, it's a burden on school, it's a burden on a child, it's a burden on a family from more than one perspective. And the more we educate school staff, teachers, caregivers, the more we find care for people with epilepsy more accessible, more understood, and more routine, the greater the benefit will be for everybody involved. And person with epilepsy, it means the whole family has epilepsy.
Correct. And I know the foundation is working on seizure-safe schools, which would address a lot of that too. We want to push that through the state legislature. So call your lawmakers. We got a few minutes left. I wanted to open it up to questions. If anyone had questions for the doctors, great resource and a great opportunity right now. Does anyone have a question that they would like? Carla Boyd.
I would love to learn more about your thoughts on AI for these neuromodulation devices and just opportunity. I mean, I think it's stunning what's coming out of that and just what you see.
Yeah, I mean, so right now there is only one device company that has the RNS. And you know, they're not like a massive company, like something like Medtronic or Boston Scientific, some of these huge companies. But they have, allocated a significant amount of their capital to R&D. In one of the areas is this machine learning. It's not really, it's not at a point now where the device itself can have the AI in it. So you actually have to send the data from the device to their central computers in California, and they'll run some of these algorithms. I think over time, as computing power becomes cheaper and more available, you'll see, more and more adoption of that into the actual device itself. It'll become more and more powerful. And I think it'll ultimately, one, it'll deliver better care because, just imagine like when you go see a doctor or an epileptologist, I mean, let's say you find the best epileptologist in the country to look at your EEG. Imagine if you had the ability to have the mind power of all of the best epileptologists in the world, right? Interpreting that EEG. Well, that's what's eventually going to come now. I did undergraduate in molecular biology, and I thought, okay, within 10 years, we're going to cure all these diseases, and it didn't happen. It's happening, but much more slowly. So I think we're in that stage now where everybody feels, okay, all of this stuff is coming down. We're just, waiting for it. So I'm very hopeful. Right now, it seems like it's going to come very quickly. But again, nobody can predict the future. But if I had to, my gut feeling is in like 5 years, we're going to see some huge changes, not only in epilepsy, but in medicine in general.
Any other questions? Mm-hmm.
Hi, my name is Peggy, and I'm from Detroit area. And I noticed that your slide that you had on the very first slide talked about 40% African Americans have epilepsy, and I was just astonished. I had no idea. Maybe it's because I think the doctor talked about the awareness, that we don't know what's going on with our children. So I'm just wondering, and I don't see anyone. It looks like me, a doctor that can address that. Do doctors, are they diagnosing that? Are they letting parents know? I used to be an educator before I retired. And so we would have seizures in the buildings. And again, as you said, people didn't know what to do. They just said it was a seizure and that kind of thing. So is there anything being done for the African-American community? Because that's just, it's like high blood pressure. They say African-Americans have high blood pressure more than any other race of people. So what's causing it to be so high in the African-American community?
Well, it is very true that a lot of times statement, someone had a seizure doesn't go far. And I think partially is because of that stigma that a lot of people experience. If they have a seizure, they try to hide it. They don't want to bring in other people to help them, support them, or know about it. That being said, I probably will not answer your question in specifics to African American community, but I can tell you that every child that shows up in our clinic or in the emergency room or urgent care, and those doctors reach out to us, more than 90% of the time, we will get them in our clinic for follow-up to investigate what that seizure was. Was it a one-time deal? Which more than half of the children who experience one seizure that is unprovoked, they have about 30% chance it will happen again. That means there's still no epilepsy. It's just one seizure. For epilepsy to be there, person has 2 unprovoked seizures that are separated in time by more than 24 hours. A lot of times it will be provoked seizure, and most common in children is a febrile seizure. That is not epilepsy. It's a febrile seizure. It's an entity in its own, and it has its own course. It has its own prognosis, implications, and we recommend different approach to treatment of those seizures. There are other seizures as a result of head injuries. And when it comes to epilepsy, I think a lot of people are scared of this word. And maybe that is partially a reason why it's not said out loud with families. I try to use it as early as possible if it's appropriate, if it's a diagnosis, which again, 2 or more unprovoked seizures. There are exceptions to that rule. Sometimes even one seizure and abnormal EEG will lead us to that diagnosis. That being said, having epilepsy diagnosis doesn't mean that we have an answer about treatment. Every epilepsy, every patient is treated differently depending on what the situation is, what is happening, and treatment of your neighbor's epilepsy and your epilepsy may be entirely different. I can assure you that nobody who comes to us is turned away. They come to us, we spend our time, we look at every child with every seizure, we ask questions. Sometimes there is not a seizure, it looks like a seizure, but it's not. Then we'll speak about that. What may it be? And one of the most common things that happen in younger children is breath holding spell. It looks terrible. It looks like they're dying, but they're not. And they may have symptoms that look like seizures. 1-to-1, you will not separate them among other children with seizures. But they're not seizures. We don't treat them as seizures, and that's why they will never have diagnosis of epilepsy. There are many different ways how this can be approached, and everyone has their own road to walk. And if you have any questions, I'm here to answer them.
Autism and all the other, I'm thinking about everything that's happening now in the world with the autism, the ADD, and all these. I guess I'm speaking now to Dr. Patra, who's the neurologist, because I'm just wondering, is there a relationship? That's all. As an African American mother and a community member, I just want to know if there's a relationship. So when I go back home and I talk to people, parents, grandparents, educators, politicians, that I can say, hey, I attended a session in Grand Rapids and I learned da 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 da. We need to get on this right away. We don't need to sit still and just allow this to go on, because our children are, as I said, I see them in my church, in the community. Things are happening, and I'm like, what in the world is going on? And what can I do is, while I'm here, to make it better? That's why, like, we are all here to make things better. So I want to make it better. I want to make it better for people that look like me.
Yeah, I mean, I think, I don't treat autism and some of those other diseases you mentioned, but just anecdotally having children with like severe allergies, it seems like everybody is having more allergies now, more autism. a lot of these theoretically autoimmune type disorders are rising, and I don't think we know why. I think there's, I think as a society, the healthcare system focuses on intervention rather than keeping people healthy, right? And I think as a society, as we put more pressure on our, on our legislators to really focus on keeping our population healthy, one, it'll prevent disease, and two, I think it'll lower the cost of care, which is just going up exponentially as well. So I think we have to make that shift. And we haven't, we're just reactionary. You have something, you come in, you get a treatment, right? It should be, how do we engage with communities early on? How do we prevent disease from occurring? And I mean, it seems like a huge task, but I think it's going to be up to, like, the people will determine that by who they choose to bring into office.
If I may add a little bit to that point, which is very good point. The disorders like epilepsy, a lot of times you can't predict, especially those with genetic predisposition or specific disorders that do not show up until certain age. The best way is obviously stay healthy, eat well, be active, be outside, play in the sunshine. However, if seizure is to happen, it will happen. We just don't know when, and we don't know who is going to have it. That's, I think, the most difficult part to cope with. There's no way to take away this inevitable uncertainty. However, once you have a problem, don't be afraid to go to your doctor and speak with your doctor. If your doctor is busy and another call and they're busy and another call they're busy, find another doctor. There are many of us out there, maybe not enough, but there's more than one that you can find access to. Don't be afraid asking questions. I know there's a lot of mistrust toward medical community. And I promise you that we work really hard to help everybody we see coming through our doors. And policies in place and laws that were made by others somewhere upstairs, we have no control over that. We can advocate, and that's what Epilepsy Foundation is so tirelessly working on. But as medical professionals, as medical doctors, we can offer help to those that we know need it. But if we don't know, we can't help.
I don't know if this has already been asked to you. I'm allowed, I'm sorry. I don't know if this has already been asked to you, but both of you, has any of your patients ever came up to you and asked you, seizures will occur around my menstrual cycle or when it's the man's time of the month?
All the time. That's one of the staples. Well, when it's geared toward particular, if you want, I definitely can speak on that if we have time for that. There is a particular type of epilepsy that's called catamenial epilepsy, where seizures are mostly happening around the beginning of the cycle or right before the onset of the period. Most of the time, it will be because the progesterone level drops significantly, or it doesn't even rise enough. And progesterone kind of helps this protective effect toward seizures, where estrogen has the opposite role. It has this little excitable properties, and it called proconvulsive properties. And in those epilepsies, if that is established, which tracking of seizures is incredibly important in that case. And that is probably a place where I should mention, look into finding a trackers for your seizures, for your epilepsy, for your medications, for side effects, especially those apps and resources that can allow you to take video and store it in their cloud that you can share with your providers. It is extraordinarily important for your providers to have that information to recognize that type of epilepsy as early as possible. And for those patients who have either suspected catamenial epilepsy or diagnosed catamenial epilepsy, which it just says that the seizures are occurring around the time of the period or cycle. It really doesn't say more about what kind of epilepsy in terms of generalized epilepsy or focal epilepsy, what kind of other treatment options should be considered. But one of the ways to mitigate that factor, that hormone fluctuation factor, is supplement with progestin-only birth control pills and allow treatment modification geared toward the time when seizures anticipated to happen. Changing the dosing around that time, adding a little short-term rescue plan for number of days when you can anticipate those seizures. There are different ways it can be done. But again, it has to be done through a process, and it takes time to figure it out.
Myself, doctors, when I presented it to the doctors, they did not believe me. They said that there's no such thing. But I think it was when I was 12 years old, I put down on the calendar when I had the seizure, when I had my menstrual cycle, and it was about 4 months afterwards, and I went presented it to the doctor. Oh, I never heard of such a thing. I never heard of such a thing. And it was about a couple years afterwards. And then finally they said, oh yeah, that will happen, you know. And then finally I says, I can't believe it. I said, I've told you guys over and over this would occur. Nobody would believe me.
I'm curious about implants for generalized epilepsy. I believe they're all initially approved for focal, but that they're seeing some promise with generalized. Can you speak
Yeah.
to that?
Yeah, so we and a couple of other centers have done several patients for generalized epilepsy with RNS and DBS. And the results are very promising, enough where one of the vendors did a multi-centered clinical trial that just closed for targeting deep brain structures for generalized epilepsy. There's an area of the brain called the thalamus that we've seen some pretty good results with. So right now they're analyzing the data. The trial is closed, but just based anecdotally, it's pretty effective. But we got to wait for the trial to be published. But yeah, we were part of that. We actually enrolled, I think, the second highest amount of patients in the country for that trial. So yeah, we're pretty active in that area of research.
I have a quick question and then we'll get it over to you. I think a stat that we've heard and we even talked about today is, despite the current medications and therapies, that still about a third of individuals with epilepsy are not finding seizure control with what is out there. And I've seen this graphic many times where it has like the timeline of epilepsy medications and treatments, and like they're pretty much used to be two, right? Initially, phenobarb and Dilantin. And then we've come into this era where all of these new treatments have and medications have come, yet that stat doesn't seem to be budging. And I know you don't have a crystal ball, but I would love your take on maybe why that is, and if you do see that changing in the future.
Well, it is true. And we look at the same slide the last 2 decades since the statistics came out. And unfortunately, that statistics is still there. Those 2 medications that we had long time ago, they're still around. And they're still the most effective medications to treat seizures. The major problem with them, they're not the best to stay on for a long time. They're very sedating. Their side effects are more difficult to tolerate. That's why they're not in routine practice to use, especially in pediatric patients. I think there's more habit of using them in older patients and adults. I can speak that for children that it is rare that we have a patient on phenobarbital that is very severe epilepsy for one or another very particular reason. I am not aware of any patients who are on Dilantin in our pediatric practice, but we use these medications all the time because of how effective they are. Newer medications that are coming on the market, they are much better tolerated. I can't say they're more effective in treatment of seizures, but they are way better tolerated. The side effect profile is much better. And one of the examples that I can give is bringing Briviac to the world of epilepsy after so many patients experienced negative effect of Keppra. Keppra is probably one of the most common prescription prescribed in both worlds, adult and pediatric. However, everybody is so worried about behavioral side effects, or those who experience them, they could be quite severe. And having Briviac in our pocket, so to speak, allows us to offer the same benefit for seizure control in patients who responded to Keppra well, but had to stop taking it for its undesirable side effects. And newer medications that universally have less severe side effects, they're more tolerated. However, the effectiveness in seizure control is not necessarily better than busphenytoin or phenytoin or phenobarbital. And this is kind of intertwined with genetics. The more we know about genetics of epilepsy, the more we can identify a specific target where we can apply our force virtual and work with more specific targets. That's where we will be able to succeed in CDKL5 disorder. That's the one I couldn't remember. CDKL5 disorder that comes with really severe epilepsy and neurodevelopmental disability. Now, appearance of ganaxolone or Ztalmy that was approved by FDA very recently, it's one of those examples where we have very specific target for very specific patient population that works way better than anything we have, newer or older medications. And this is the part that we obviously very excited about. Development of new targets, identifying of new targets in genetics that allows us to find new targets in pharmacology that can bring more benefits to specific patient populations that unfortunately cannot benefit from currently existing medications.
Just a follow-up comment. Yeah, I think it has to do with being selective in your therapy. A lot of the therapies are just so general. Eventually, the side effects are worse than the actual disease. So there's some surgical therapies coming along. There's 2 clinical trials we're starting this year that we're enrolling for temporal lobe epilepsy, where we're injecting gene therapy for temporal lobe epilepsy. So we'll kind of selectively just that same structure that we remove and treat with laser ablation. Instead of laser ablation, we'll be injecting that area with adenovirus vector with a certain gene that down-regulates a receptor that's overactive in that type of epilepsy. So the preliminary results, that have been done are quite promising. It's showing reduction in seizures and actually improved memory function of the hippocampus. But this will be really a first large-scale, first-in-human study that we'll be a part of. And the second trial that we're going to be a part of is more of a stem cell progenitor trial, where we'll be injecting progenitor cells in that same area. Again, very similar. The feasibility study showed similar promising results, so we'll be starting that as well, and hopefully enroll patients this year for that. So, I think there's been a lot in neuromodulation, but now, kind of gene therapy and stem cell is also part of it. So there's just a lot more, I think, potential options that are going to be available in the next 4 or 5 years.
And I might add that in the last decade, the tendency is toward considering surgical treatment in children much earlier than it used to be. And children that undergo surgeries for epilepsy are getting younger and younger. And that includes neuromodulation. We have some young children who also have RNS implanted. And that is also changing in landscape in our pediatric world.
I think we have another question.
Hi, I actually wanted to piggyback on her experience. I was I started having seizures about 5 years ago, and I was diagnosed 3 years ago. And you spoke to kind of keeping that track with regard to your menstrual cycle and things like that. And I did take that and present it to my neurologist. I was prescribed the generic trileptal, but my neurologist, there was a lot of back and forth. So my neurologist would refer me to my gynecologist would refer me back. And they basically were saying, like the gynecologist was saying, if you do like the progesterone heavy birth control, it would essentially counteract the effects of the trileptal. So she told me she didn't want to prescribe that because she didn't want to offset that. And then the neurologist said the same thing. And so the trileptal was actually causing the seizures to be more intense. And I actually stopped taking it because they were much more severe. Minor, I'm more aware when I have them, but I was losing memory, experiencing somewhat blackouts. And so do you have a recommendation? Is there a specialist that focuses on catamenial epilepsy? Because like I said, it's been some years and it's just kind of been a back and forth. So I just haven't had a lot of success in trying to get some help with that.
Unfortunately, I may not have a specific reference for you for the person. I'm not that well versed in adult world. However, anyone who treats epilepsy as their bread and butter, they are able to take care, and they're very much capable of taking care of catamenial epilepsy. That being said, I actually agree with your neurologist referring you to gynecologist, because there are aspects of treatment that needs to be discussed with you in person, and those are much better done by the specialists that routinely handle those medications. I can tell you that I would like to see the effect of progesterone, but there's so many other implications outside of epilepsy that I prefer gynecologists having that conversation. Now, as far as your comment about progesterone overcoming or decreasing effectiveness of the trileptal, that is misconception. It doesn't decrease effectiveness. They interact and the level of the medicine may decrease, meaning the dosing needs to be adjusted. But the other part of it, that trileptal made your seizures worse, that what makes trileptal not the medicine you can benefit from. That definitely was the right call to stop doing it. But I would encourage you to go back to your doctor and do that with your doctor at your hip. As far as again, I don't think I even heard of catamenial epilepsy specialist, but any epileptologist is very much capable of helping you with treatment of that epilepsy.
I think we have a question.
How big of a factor does diet play into epilepsy? It feels like sometimes that there are certain foods that will either send triggers or completely neutralize the effect of the epilepsy, all depending on where we are in the dietary process.
There's only one specific diet that comes to mind that makes significant impact, and that is a ketogenic diet and its versions. As far as regular diet, there's no major changes that I observed that could make meaningful impact on epilepsy. What I have seen, and that is usually in the context of, let's see how reduction in drinking soda and removing the bread and removing some other high carbohydrate content food kids will tolerate because they love their sugars. And in that process, in some instances, we can see decline in seizures, even without going into ketosis. Carbohydrates, specifically sugars, they may have some pro-inflammatory inflammatory properties, not by itself, but they promote the cascade that leads to that increase in inflammation level in the neuron. And that may promote seizures, and that gonna help seizures to happen. It's not the cause of seizures by any means, but like in any things like cupcakes to diabetes, It doesn't cause you diabetes, but it makes it worse. So one thing that I may suggest is eliminate highly processed, simple carbohydrates that are everywhere, unfortunately, these days. Just watch what you eat and don't go heavy on that. Short of ketogenic diet, I don't think other changes would be more meaningful. But being healthy is just how you help yourself.
GABA, it's like it starts. Can you speak to that?
I know it's in health stores. As any supplements, there's a lot of anecdotal reports that people benefit from. However, it is not the same GABA that floats and interacts with our neurons in the brain. The GABA that you ingest gets through your digestive tract and it's broken down into little parts and pieces that needs to be carried across the barrier in the gut and into the liver, and it goes through the metabolism and then whatever is left over in the blood. And I don't believe there are any good well-powered and randomized controlled trials that are gold standard for effectiveness of anything. Have been done with GABA, but what has been observed is not that radical to say you should do it. But then again, why would you do it? Why do you need GABA? What do you plan? What are you hoping to benefit from? There's one medication that is called gabapentin. It was originally designed as a seizure medicine. But over time, we learned that it works much better for some other things, not so much for seizures. So when you take something, there is a goal for it. There's a reason for it. And if you reach your goal, I guess you benefit from it. If it doesn't harm you, it doesn't burn a hole in your pocket, it makes you feel better, absolutely, why not? If you're looking for specific results, then I would suggest you speak with your provider, because I'm sure there will be more than one medicine that needs to be considered in the combination with any supplements that you want to take. And that probably will be more meaningful than not take something.
That'll have to conclude our discussion. Doctors, thank you so much. That's very informative. All right. Welcome back. Hope everyone enjoyed brunch and that time, as Brianna was saying, to connect. Good conversations out there. Thank you very much for being present for our final session of the day. This is titled Community Innovations, Creative Solutions to Overcoming Challenges. And today we're going to learn from three panelists who will inspire us to be creative as we take action together in the community. Would you please welcome, from my left to right here, Maanya Tarnal, Sarah Stempky-Kime on the end, and Jonathan Couchy. Let's give them a warm welcome. Sarah, I'll start right down at the end, and why don't you introduce yourself and tell us about your journey here today?
Good morning. My name is Sarah Stempky-Kime. I am a parent of a child with epilepsy. My son, Alistair, was 4.5 months old when I saw his first seizure. I don't know that he wasn't having them before then, but I'll never forget it because it was the night of our 7th wedding anniversary. So that was supposed to be like your lucky year, right? And he started doing the teeniest little head drops. Any infantile spasms families here today? Okay. So his seizure type is infantile spasms. Before I took him to the hospital the next day, no less than 10 doctors had seen the video of what I called his episodes. 9 out of 10 of them told me that it looked like reflux and nothing to be concerned about. The 10th doctor was an epileptologist and told me to bring him to the emergency room the next day, which I did. He was diagnosed in the ER with an overnight EEG with hypsarrhythmia, which is the hallmark pattern for infantile spasms. The next day, a team of doctors came in, they looked at him, this giant 4.5-month-old healthy baby, and told me that they thought this would be a blip on the radar. We were going to start a treatment called ACTH, which I'm sure some of you are familiar with. It's an injection. The ACTH did in fact stop his seizures. They stopped them quite quickly. And we thought that that would be it. As soon as we weaned, they came back. We started our next medication a couple weeks later, vigabatrin. Any vigabatrin families here? No? Okay. People have a love-hate relationship with vigabatrin. I happen to hate it, but that's mostly because my son became toxic to the medication. His relapse was in March of 2020. So just before OG COVID is what I'll call it. I ended up getting a second opinion at UCLA, which thanks to COVID, I was able to do virtually. And I'll fast forward for now, but I ended up flying him out to UCLA in May of 2020, where he had a hemispherectomy in June of 2020. So he had a left hemispherectomy, which is essentially the removal of the left half of his brain. But his hemispherectomy was functional, meaning that they disconnected half of his brain and they leave in most of the brain matter, though they did remove the left frontal lobe for pathology. The cause of his seizures was determined to be focal cortical dysplasia, which is a malformation of cells, and I knock on wood a lot, but hopefully isolated to the left half of his brain. So turning off the left half of his brain stopped his seizures. We believe he's been seizure-free since surgery, so we're coming up on 4 years. So that is the nutshell. I'm sure that I'll be talking to you a lot more about that, but that's the overview.
Sarah, thank you. Jonathan?
My name is John Couchy. I'm a inclusion consultant and trainer over at Disability Advocates of Kent County, which is a local nonprofit organization, a part of a national and statewide network of organizations. I've worked in disability services for, I can't believe I can actually say this, but 16 years. I know I look way too young. I myself am very passionate about just the world of disability and ensuring inclusion and accessibility. As you guys probably saw, I am an individual with blindness, but I also took advantage of the buy one, get a dozen free deals when it comes to disability. Epilepsy specifically is very near and dear to my heart, as I have a close family member who does live with epilepsy. So when you guys reached out, I was more than happy to participate.
And we're fortunate that you're also a practicing stand-up comic. Maanya?
I'll be performing May 26th at Woody's.
Hi, Maanya.
All right. My name's Maanya Tarnal. I am a sophomore at the University of Michigan, and I'm studying public health. And then I just kind of want to go into my personal connection with epilepsy. So I do have epilepsy myself. I was diagnosed at 16. So it was kind of later onset. Pretty confusing. I had my first seizure November of 2020, but there weren't that many witnesses. So I was taken to the ER and told, you just passed out, we'll refer you to neuro. So I go and see neurology, get an EEG done. There was a spike. However, my neurologist was like, we'll just play a waiting game. I don't want to put you on medication quite yet. And then I waited my 6 months to drive. 3 weeks after I started driving, I had my second seizure, and that was May of 2021. And it was definitely hard. It was isolating, especially because I was still, during online school. But flash forward 3 years later, I am seizure-free. That'll come up next week. So that's super exciting. Thank you. And then in terms of my connection to the Epilepsy Foundation of Michigan, I was their public health intern last year. I'll get into that a little bit later, but I conducted the 2023 needs-based assessment and I learned a little bit more about epilepsy and its prevalence in the state.
And we're going to stay right with that. You just touched on it, Maanya. You were a public health intern for the Epilepsy Foundation. Give us a little bit of an introduction to what the 2023 Epilepsy Needs Assessment Survey was. Tell us about that project.
Yeah, absolutely. So the 2023 needs-based assessment was to kind of evaluate, in the name, the needs of people with epilepsy in the state of Michigan, as well as their friends and family, because we do find that super important. Support groups with people, like around people with epilepsy, are super important as well. The main factors that we focused on were demographics. So who was getting care, who wasn't getting care. We talked about access to care as well. What did that look like demographically, but also geographically? We did find that the north part of the state did not have that much access to epileptologists, neurologists, and centers in general. And then the last aspect of it was SUDEP. It's a very tough conversation. However, it is an important conversation. So I advocated to put that out there. So we kind of took that data and learned a little bit more about what that looks like in the state.
And let's elaborate on that. I guess tell us some of the most significant findings that you were stumbled upon in that survey.
Yeah, absolutely. So we evaluated the quality of life. So we talked about social being, mental health, physical health. We did find that a lot of people did struggle with their mental health as well as their social being. And that was significant. Like I mentioned earlier, epilepsy can get lonely. So we found that. And then additionally, the SUDEP section, we did find that 53% of people were not educated about SUDEP during their diagnosis. So kind of flash forwarding to that, we're talking about advocacy and what that looks like as well.
Sarah, you shared a little of Alistair's story with us. I'm just curious from the standpoint of a parent, some of the challenges that you faced and continue to face, and the sense, I guess, do you have a community that you can rely on? Does the foundation help? Talk a little bit about that.
Sure. So the challenges that we face now seem really minimal compared to a lot of the people and the families that I know who regularly and still hold their children as they seize, and there is no end in sight. So while Alistair had to give up half of his brain, we have had a period of seizure freedom. So his challenges now relate to his physical and cognitive disabilities, the extent of which remains unknown, because the follow through for kids with hemispherectomy and brain surgeries is still a really underserved area of research. And there are some organizations that are trying to change that. But even within the medical community, I've noticed with our treaters, there's no linear way in which these children recover. So there's no prescribed way in which a doctor can tell us do X, Y, and Z, and that's going to give your child the best outcome. So cognitively, Alistair is hilarious. He is in the normal range for speech. I think a lot of us in this community probably have come to hate the word normal. I do, but that's what we use on a lot of inventories. You know, he swears, he calls his siblings bad names. He does, you know, but he has creative answers to things. He processes things differently. I'll never forget in his IEP 2 years ago, they asked him, you know, what do you do with a glass of water? And they're looking for you drink out of it. And his answer was, I dump it on the floor. And so that is technically a correct answer within the normal guidelines. Having surgery for me was not a challenge because I thought he was going to die if he didn't. So I was hoping that he was a surgical candidate, because the alternative for me, I was convinced that his seizures, if not a structural cause, were related to a POL-G mutation that he had that they deemed insignificant because he shares it with my husband. But the POL-G mutations are very scary, and so were his seizures. He was in a state of decline. So I know that there are a lot of families who view epilepsy surgery and particularly probably hemispherectomy because it is the biggest one, as a last resort. But for me, it was a chance for him to have a cure. He is not yet med-free. I hope someday he will be. It terrifies me for him to be med-free. It terrifies me for him to never be med-free. But surgery to me was a lifeline that UCLA was going to speed up for us, whereas our local hospital could not work as fast as them. So, I mean, I don't know that anybody ever says thank God for COVID, but like that was what let me take him across the country for 6 weeks. I'm a practicing attorney. My work has never been remote. And then, you know, in the blink of an eye, everything was remote, and I was able to go to California for 6 weeks. So now the challenges are, what is the best type of therapy? You know, what is the best chance that we can give him to develop? A lot of the therapy that is best for children with hemispherectomies is an intensive model. And we know that insurance doesn't cover a lot of that. So when we do intensives, we go to therapy. He's in one right now. We go every day for 3 hours a day. And it's really freaking expensive. But how can I say I'm not going to do this out of financial concerns? And yet I have the privilege to be able to say that I am going to do that and pay for it. And most people, many people who are in this situation can't. And that's really just unfair. Why should one child have a better opportunity to develop after a major surgery than another child because of socioeconomic status? So that is a big challenge for me. It's something that pisses me off regularly. But the future is really, it's unknown. Every day without a seizure is a gift. It is not guaranteed. It could change at any moment. And so we just work as hard as we can to allow him to develop as much as he can in the meantime.
You're working hard, you're giving him opportunities, but you also have to be creative
Yes.
too.
Yes. So creativity for us was, I mean, everybody hates Facebook, but like, and you never want to talk about like crowdsourcing your child's medical status, but there's so much of that happens in the Facebook groups because our treaters didn't have a lot of suggestions for us on where to go. They're like, oh, you know, just find someplace to go for therapy. And it's the other parents that have been through this that are talking about, you know, we flew across the country for an intensive, and out there I met a mom from Michigan who told me about this amazing Italian man in Howell. Nico is his name. And have you met Nico? No, I haven't met Nico. And now I have friends that fly in multiple times a year to see Nico. He's I guess you call him a physiotherapist. And we see him more than any other therapy because he looks at the body as a whole. So he's looking at how Alistair's arm moves when he's moving his leg, or how he's using his core when he's moving his arm, or even the way he's turning his head. Is he trying to rely on the remaining right half of the brain? But we want him to acknowledge the other half as well. So creativity for me has been like building this community of moms, mostly. I mean, no shade to you dads, but it's the moms that I have connected more so with, many of which whose children have also had hemispherectomies, and we are bouncing things off each other all the time. What is working in therapy, in life, in school, and I mean, honestly, kind of keeping each other sane. I met one parent prior to Alistair's surgery whose son had had a hemispherectomy, and she became my lifeline during the time of his surgery. I thought I was not going to, it sounds so dramatic, but like I was just like, I cannot remain in this hospital. I can't keep doing this. But the day of his surgery, she came and walked with me for 8 hours. I'd never met her in person, and she walked with me the entire day. And now she's one of my closest friends. And her son had just had the surgery 2 months before mine. So I wanted to kind of hide from people after seizures started with Alistair. I wanted to hide from my friends and my family because I felt like they could never understand what I was going through. And as much as they wanted to, I didn't need to hear anybody else tell me that they were sorry for what we were going through, because I knew they were sorry, but they also couldn't possibly understand that, you know, our lives had been fundamentally and forever altered. And so I kind of withdrew. And then even after his surgery, I didn't go back on the chats and the boards and all of that because I just felt like I retreated into myself. But it was when I opened back up and started meeting more, other than my one friend, meeting more people whose children had hemispherectomies, hashtagging on my posts so that people could find me. And then I've sent other people to our neurosurgeon. And now I have a community of people, of half-brain children that I'm dear friends with. And that is what has saved me in some of my worst moments.
Building that sense of community is so important, as we were saying in that last session. We were talking also about good AI. That's good use of Facebook.
Yeah,
too.
I know. You know, I mean, like, sounds like an oxymoron, right? But it has its purposes.
No,
I guess.
absolutely.
Yeah.
Jonathan, let's talk a little bit more about your work as an inclusion consultant and trainer, especially in the context of advocating for those with disabilities.
Yep. So the organization that I work at, our big goal is creating a more welcoming space for individuals with disabilities. When we're talking about home, community, and employment, as an inclusion consultant, I get a lot of opportunities to work in two of those sectors. When it's talking about access to employment, I'm going out to businesses on a weekly basis and presenting to them not only on general disability awareness, but diversity, equity, inclusion, and most importantly, accessibility. We get to talk about what is ableism. We get to do a series of trainings with different organizations all throughout our area to ensure that they are becoming a more welcoming space for people no matter what their ability level is. On top of that, I can work in the education sector to provide that education as well. Something I'm very passionate about is the fact that disability has been kind of scrubbed from our history. And disability, I mean, that's 27% of our population. It is a large portion, so being able to educate people on that front. Used to host a podcast called Flattening the Curve, where we would highlight disability stories as well as the work that's being done in our communities. That podcast will be coming back soon. So some of you I might be reaching out to do some interviews with. But really, that's the big thing that I do as an inclusion consultant is I work with businesses and organizations to become that more welcoming space to really highlight inclusion and make sure that accessibility is at the forefront of all design.
Talk about some of those obstacles specifically that those with disabilities face here. And well, it seems like it's obvious, but how are you addressing those barriers?
Oh boy, that's a loaded question. I mean, barriers for individuals with disabilities, we walk into them sometimes literally every single day of our lives, no matter what space that we're in. Our world was not built for individuals with disabilities, and historically we have not been truly considered when it came to our community. So looking at those barriers, it's how do we eliminate those barriers? We talk about the social model of disability, which is often emphasizing the fact that so many of those barriers are due to the environmental constructs. By eliminating those barriers, we eliminate so many of those inability feelings that individuals have with their disability. The other thing is really focusing on strengthening people's views on the word disability. When we talk about language around disability, I can go on an hour-long lecture on just language in general, but disability terms have been used as insults in our culture for a long time. How disability has been treated throughout our history has been very negative, and most people, when they hear that word, they think of it as a dirty word. Disability is not a dirty word. It is nothing to be ashamed of. It is nothing to sweep under the rug. It is really just another level of human diversity.
I love that answer. And you've had to get a little creative. We were talking creativity earlier. You have had to get creative too to get that message across. Give us an example of that.
Well, I mean, it's always trying to connect with people first and foremost, and to take control of the narrative. People assume every day when they see my white cane walk into a space of what I can and cannot do. And really, it's not their place to put that label on me. So I control that narrative. Something like employment, walking into job interviews when I have a white cane, man, everybody's thinking, oh my God, what's going to happen? So I utilize that and can kind of shift the narrative. I never speak negatively about my vision. I never speak negatively about my disabilities, because if they hear negativity coming from me, that's all they're going to think. So I really shift it and shape it as a strength. Why is hiring somebody who's blind a great idea? Well, because I problem solve 24/7. I look at with a different perspective. I come at it with adaptability. I'm used to thinking on my feet. Things along those lines, when you can really shape that narrative to one person, that really spreads and is a contagious way of looking at it, to where I leave businesses and then they come back to me and they're like, okay, how do we hire more people with disabilities? Because people with disabilities are some of the greatest problem solvers, are loyal employees, and do bring a lot to the table. So really, it's opening people's eyes with the fact that, first and foremost, we're not disabled people. We're people with disabilities. We are a person first, and we bring a lot to the table.
Maanya, as someone who lives with epilepsy, as you said, how did your personal experiences inform your work, and especially that work on the survey? What did you bring to the table, I guess, from your own personal experience that you were able to illuminate others with?
Yeah, so I consider myself very, very lucky with my epilepsy journey. I reacted well to medication, and I definitely recognize my privilege there. And so I think part of that, recognizing the privilege, is how I approached the survey. In terms of my personal experiences, I really took the experiences of people that I met at these Epilepsy of Michigan conferences. I've heard so many stories and so many journeys, and I take that to heart. And so the questions that I asked and the way I designed the survey was keeping in mind all of these amazing people that I've met.
Sarah, I'm curious, as a parent, and you were able to find your community. You must have others, though, that come to you for advice. Are you in a position where you feel like you can now start to dispense some of that knowledge?
It probably depends on what the topic is. I know my limitations, or I think I know my limitations. When we're in the groups and someone either comes to me directly, or I hear of someone that comes in with a difficulty, and their child is having infantile spasms, or they've been told they can't find the cause and they feel like they're running out of options. What has become really, I mean, honestly, it's just become so prevalent that a lot of people are in geographical areas that are underserved when it comes to epilepsy care. And so a lot of children are victims of a system that doesn't know how to serve them. The doctors don't recognize the seizure types. They don't know how to diagnose a cause or look for a cause. They assume, they do a regular MRI, a CT, an EEG, and they don't see anything on the MRI. So they chalk it up to, I don't know, genetics, or they can't find a cause, and tell parents that that's a good thing, which is what we were in the beginning. Oh, we can't find a cause. You're probably idiopathic. It's going to be a great outcome. Well, there is a cause. there's a cause somewhere where whether or not you can find it on genetic testing or on an imaging. In Alistair's case, the focal cortical dysplasia is often difficult to visualize until a child's brain is more formed as they get older. But there's clinical signs too. So he immediately had weakness on his right side, which is an indication that something is going on the left side. And our original hospital system did correctly say, oh, it could be this focal cortical dysplasia. We want to wait till he's older to operate. But the place where we end up getting the second opinions, like, yes, yes, no, he's a house on fire. So let's get the testing done. And if we can confirm that it's a focal cortical dysplasia, or in our case, they never 100% confirmed it, suspected, they proceeded with surgery anyway, based on the data that they had. And so I had a friend in Atlanta who their doctors just kind of threw up their hands. They told her definitively that her son was not a surgical candidate, and they would just have to treat his seizures. And then she got a second opinion at a level 4 epilepsy center and ended up having a hemispherectomy and has been seizure-free since. But if you don't find people that urge you to question the information that you're being given, or if you don't have a natural inclination to be suspicious about the information that you're being given, then often your child is going to suffer as a result. And it's really hard to say, because there are amazing, amazing doctors that know how to treat epilepsy, different types of epilepsy, doctors, surgeons who, will do epilepsy surgery. But there are a lot of doctors who don't know a lot about it and don't know that they don't know a lot about it. And so I think that we as a population are generally not inclined to be suspicious of doctors or of information that we are getting from authority sources. And so I don't want to sit here and be like, my creative advice is to be suspicious of what your doctors are saying. It's not. But knowing where you're treating, knowing the credentials of your treatment team, the experiences that they've had with cases like yours, but then talking to parents and knowing, I got the idea for our second opinion from a parent in a group. I have passed his name on to many people, but I think that a lot of people don't have, or in my family, my husband, he wanted to believe what our original treatment team was saying, which was, he's going to be fine. We can take our time. We'll just try. In our case, they wanted to just try keto for a few months and just wait it out while we did surgical testing. And it would have been a long, drawn out process. And my husband was very comfortable with that, because it made him feel as though our son was not in an emergency state. But he was. And I think that my husband's personality type made it so that he was like, okay, great. We'll let things play out. This isn't something, and that gave him permission to not panic. And maybe panic, which is what I was doing, was not the appropriate reaction either. But had we been complacent, our son would probably look very different than he does today, because his brain was, it was in a constant state of chaos, and the damage that would have continued on the good side, I just don't know what his outcome would have been if we had waited 6 more months to have surgery, or a year, or 2 years in some cases, which is what happens.
And have that healthy skepticism, or
Yes.
be willing, I guess, kind of to push.
Yeah. And I'm a lawyer, so probably some of that comes more naturally to me than other people. But, I'm also a worst case scenario person when it comes to this stuff. So, there were times where my husband and I had roles where I would toss out the worst case scenario that I found on Google. And then his role would be to tell me I was wrong so that I would feel a little bit better. Not the healthiest way to operate, but that was what we were doing. You know, I would be like, well, he's going to, you know, die in a month, according to this article. And then he would, you know, call our doctor. I mean, that this is a little bit of an exaggeration, but not too much. I mean, that's really what was happening in our house. So even if he were panicking on the inside, it was his role to not show it. And it was his role to let me be the one panicking and then calming me down even. And so in that way, I probably robbed him of some of his, you know, his outwardly expressing anxiety and fear in the way that I was. So I don't know that my skepticism was healthy in so much as like consuming, but I think healthy skepticism is a great thing to have.
Yes, okay. Jonathan, let's get some practical advice, I guess, for those of us who may be facing challenges in the workplace because of epilepsy or any other disability. What is your real world advice to kind of advocating for yourself and getting some of those concessions, if you will?
So I'm going to sound super cliche here. Some say knowing is half the battle. I mean, knowing is entirely the battle. You need to know yourself first and foremost, but also know your rights. And to go over that, understanding your rights under the Americans with Disabilities Act, which, by the way, is a very young law still. I was born a month after it, so we will not call it old. The ADA does have a lot of protections when it comes to discrimination, as well as when it comes to accommodations in the workplace. So knowing as an individual what your rights are when it comes to seeking out those accommodations, who to talk to, what are possibilities, and then most importantly, knowing for yourself what's going to be beneficial for you. And something to be aware of, for a lot of individuals with hidden disabilities, disclosure is 100% your right. You do not need to disclose your disability. Nobody can ask you about it. But if you do need any form of accommodation, you have to be the one to disclose that and initiate that conversation. And it is so much better to address that concern, address that accommodation before something becomes an issue. If you're in the workplace and uh-oh, my disability's flaring up, I'm having an episode, I'm having whatever it may be, and then it becomes an issue in the workplace, it does not look good to then come up to your boss and be like, hey, so here's the cause of that. You want to address it right away. Practically, I can say human resources is the way to go. Many people think I talk to my supervisor. Most supervisors in most jobs are not familiar with ADA law, and they are not bound to it in the same sense as human resources. They are bound to confidentiality, and they are most familiar with that law. As an individual, when you're seeking an accommodation, you do need to be aware of it is a negotiation. You can't walk into most employers and say, hey, I work in a grocery store. Fluorescent lights really bother me. We need to replace this entire light system in this place. They're not going to do that. That would be considered an undue hardship. So know yourself, know what could benefit you, know that it is going to be a negotiation. And what often helps in that negotiation process is explaining to that employer how helping you helps them by getting them a more efficient and more effective employee. Do be prepared, though, when working with human resources, that unless you have a disability where it's very clear that you have it, like me, I'm literally waving a white cane in their face, you will need to provide some level of documentation and proof when disclosing to human resources.
I want to ask some questions of the panelists collectively. So this is for all three of you, and I'll start with Maanya. Who are some of the individuals or communities who have inspired you as you think about how you've overcome the challenges that you face with epilepsy?
Yeah, absolutely. I think first of all, my parents have played a huge role in my approach to things. I know it was hard for all of us to kind of cope with my diagnosis, but they've been the biggest support system. Stemming off of that, everyone at the Epilepsy Foundation of Michigan are so near and dear to my heart. They inspire me to be the best version of myself. And I've learned a lot about public health as a field. I think after my public health internship last year was what drove me to the field of public health. And then, of course, just everyone around me has inspired me a lot to take my diagnosis and my experiences and make the best of it. I am big on patient advocacy as well. But yeah, all of those experiences and the people I've met have inspired me a lot.
That's awesome. Sarah, same question. Who inspires you?
I mean, I feel like you guys are hearing a lot of topics that are going to be conversations with my therapist in the future. I have a major heroes complex when it comes to our neurologist and our neurosurgeon. Our therapist that we see, Nico, I feel so safe when I'm with him. But it's parents. I didn't meet anybody from the Epilepsy Foundation of Michigan until after Alistair's surgery. And seeing the work that the foundation does to support families, and the stroll and Toasting Hope and the events that are meant to bring awareness to our community, it feels like a lifeline in a lot of ways, because there is so much of what we go through as parents and as patients that feels really isolating, and it doesn't have to be. So that would be the tip of the iceberg for me.
John?
So I woke up one day when I was 12, and that's when I lost my sight. I was the only person I knew who was blind at the time. I met a man named Dr. Paul Ponchilla and his wife, Sue. They were Western Michigan University professors who started up a sports education camp for athletes with vision impairments. And it was really getting there and seeing so many amazing individuals who were doing amazing things. At that point in my life, it was despite a disability. I'm meeting individuals who are blind, who are lawyers, Paralympic athletes, high-end tech fields, things that I thought would never be a possibility. But it was through meeting individuals like them through that camp and really creating that sense of community that showed me what I was capable of. And even working over at organizations like Disability Advocates, where I see individuals every day, because all disability is a spectrum, everybody is unique. But seeing individuals who do face barriers, but don't only face barriers, they conquer barriers, that inspires me every day.
Again, this is for all three of you. We know that people can find a deeper sense of identity and belonging when they take action in a shared direction. This is going to kind of be tough. Can you think of a meaningful moment in your life when you witnessed this? Oh, that's a tough one.
I mean, that camp I brought up. I attended this camp when I was 12 and 13. I started working it when I was 16. And the whole purpose was taking individuals from the sidelines to the goal lines and watching these individuals come in not knowing what they were capable of and leaving and going to advocate at their schools to participate in athletics. Not all these kids were only facing blindness. They had other disabilities as well, but they could advocate for what they could do and would succeed in their field. And gaining that confidence helped them succeed in school, in their careers, and so on. Things like that, like to me, that's those little moments, they all add up and great power.
I'm still having trouble kind of figuring out what specific moment. I think for me, kind of stemming off of camp, I volunteered at the epilepsy camp that we host every year last summer. And I think my experience there in general was just so eye-opening. I dealt with the, like, I believe it was like 11 to 14-year-olds at that camp, and just seeing how positive they were and how open they were to just having, again, like Sarah said, don't like the word normal, but a normal camp experience was so amazing to see. So just stemming off of that in general, it's just so inspiring and so heartwarming to see them taking something and just making the best of it.
Those camps are critical. Absolutely.
It's not, it's kind of like a camp, if all of us are going to talk about camps, but last year there were a group of 50 epilepsy moms who took a trip out to Zion, and most of us had never met each other before. Many of us were acquainted with each other on social media, and in fact only knew each other by our kids' names. Like, you know, I would be like, hi, I'm Alistair's mom. And some would be like, hi, I'm Jordan's mom. And be like, oh yeah, okay, I totally know. And I would know their kids' like medication history, like surgery history. I knew them better than I knew the parent. And then there was a mom there who lost her son 3 years ago. Now it was 3 years in April. And his cause of death was infantile spasms, and she came. And I think that, you know, for some of these moms, they are administering rescue meds on the regular. Their children will never sit up unassisted. Many of the parents there will lose their children before they die. But it's the knowledge that, and maybe it's time, you know, in this process, this journey, whatever you want to call it, that grief and joy can coexist. And that's not something that I could accept in the beginning. I still find myself being a little overwhelmed by the grief part of it, not because of who Alistair is, but because of what he will continue to face. But a collective group of people who try and choose joy alongside of the grief that they experience every day. That was maybe the most powerful moment for me.
All right, last one for all three of you, and then we'll open up some questions if we have it on the floor. And this is the last one. What encouragement would you give our gathered community here if they're facing some of those unique challenges and they're seeking creative and lasting solutions? How about a little encouragement?
For me, I think just reaching out to your support system, like I mentioned previously, things get lonely, it's hard, but having people around you to support you and encourage you would be my biggest piece of advice. That's what got me through a lot of the things that I was dealing with. So just emphasis on leaning onto the people around you, because those who care are not going to find it a burden to support you.
I mean, again, gonna sound a little cliche, but we only have one life to live. Don't stop living. Don't let those barriers that are in your way consume your whole life. Still make time to live. And when you do run into those barriers that might be stopping that forward progression, do know that backing up, turning down a different street, and finding a way around that roadblock is 100% an option. Just because you're moving in a different direction does not mean you're still progressing forward.
That could be a bumper sticker.
I know, I'm cool
Long
with
one,
that.
but good one. Sarah.
I think staying curious, asking questions, and knowing that asking questions doesn't make you disrespectful. Second opinions, whether it's medical second opinions, whether it's bouncing ideas off of other people, I think is the best tool that we have to find out about things that are working. I mean, there are new medications coming out all the time, you know, talking to other parents. If a VNS or an RNS is an option for you, talking to other parents about real lived experiences, but then also not being afraid to question the information that you're being given, and then taking that information and asking the people who have lived it. because there's really no replacement for a lived shared experience.
Thank you so much, all three. Sarah, John, Maanya, great answers. Very inspirational. A round of applause for and we want to that was me. We did want to open it up to questions. If there were anyone that had a question for our panelists out there.
Hi, I did want to ask, I know, Jonathan, you spoke to the disability portion, like within your job. I was just speaking to Renee about that actually, when you do job applications and things like that. And one of the questions that they ask you on there is, do you have a disability? And of course, there's the option to not disclose, but I, again, didn't realize until a few years back that epilepsy, one, was considered a disability, because all of this was very new to me. But then also, if you don't disclose, or if you simply say no, and obviously the answer is yes, have you noticed that, there have been sort of some clashes with that where it comes to employment? Have you seen that happen at all, or?
So I'll get a little technical here. It is 100% illegal for any job application to ask you if you have a disability. The closest legal question that they can ask you is, can you perform the essential functions of this job with or without an accommodation? Now, many job applications for any employer that is receiving any level of federal funds and with a lot of DEI initiatives, they can send an optional form. Keyword there is optional form. That is a self-disclosure form. Nobody has to fill that out. That form should only be shared with human resources. No hiring manager should see that form. So again, disclosure is 100% your right. But I will say we do run into a lot of barriers when it comes to applying for jobs. One question that is a massive pet peeve for me is the question, do you have a driver's license? As an individual who's blind, that is a barrier for me. I know that is a barrier for a lot of individuals with epilepsy. When you read that, you're sitting there going, I can do every function of this job. I can get around town, no problem. I take the bus, I take Ubers, I have a personal driver, whatever it might be. That question really is asking, can you get from place? Do you have reliable transportation? And can you legally work in the country? They need to shift how they're asking excluding questions and create more inclusive questions. So there is barriers that people face every day in that sense of applications for jobs. But the question of, do you have a disability, should never be one. If you do run into issues like that, do contact Disability Advocates of Kent County and we can help you investigate and file a complaint with the Michigan Department of Civil Rights.
And just as a follow-up, so would the piece of advice on that written application that she was referring to just to be to leave it blank?
It's an optional form. You can just say, do not not applicable. You can leave it blank. They cannot hold that against you whatsoever. That is an optional form for federal funding to meet quotas. It should have no impact on the hiring process.
Question in the back.
Sorry, I had to step out a minute, so I might have missed this if you already said it. I'm a nurse in a epilepsy clinic, and I get a lot of patients who will call that have had a seizure at work. Their employers then want a letter stating that they're safe to come back to work, which we oftentimes now are saying they can go back to work to complete the duties they were previously employed for. Or if we have like the standard precautions about avoiding heights, no sharp moving objects, we don't want people to be running big blades and have a seizure and fall in and get cut or something, things that they could get hurt on. But I've had employers come back, even though the person may be employed in a position that there's none of these precautions, they want them to have absolutely no precautions. And they'll say, if we can't sign that, they'll lose their job. I actually referred one gentleman to the Epilepsy Foundation. His manager called and said, we need this to state this. And I told her, I can't discuss this with you per HIPAA law, first of all. So he signed a release of information that I could speak to her. So when she did call back, she said that they needed it to say that he didn't have any precautions. And I said, well, does he do any of these things? And she said, no, but for his employment, we need it to state that he has no precautions. I said, well, you know, you could always contact the Epilepsy Foundation. I'm sure they have information about discrimination that you could talk to them about. I never heard from him or his employer again.
Good for you.
Okay, yeah, so I was wondering, like, what was the question there?
Yeah, just, is it legal for them to tell us we have to put precautions, or if they aren't working in a job that has these, how can they state that they can't have precautions? Like, is there a legality there?
In my personal opinion, if they can perform the essential functions of the job, that is all that matters. There are lawyers who can better handle that. That's getting a little into the weeds on legalese, and questions for the Michigan Department of Civil Rights or the Equal Employment Opportunities Commission, which for a lot of cases like that, an organization like Disability Advocates or the Epilepsy Foundation can probably help to determine if that is a massive issue and to help forward that along to the higher authorities, because that does sound very questionable to me.
Any other questions? One more?
Let's see if I can talk. I'm getting ready to reapply for a job that I had a doctor's report of limitations that I could do on the job. And they felt that by the doctor's rulings that I could only stand 30 minutes at a time, sit 10 minutes, that I was not capable of doing the job. Thinking about going back to the job, how can I undo when I told them I cannot work under the standards of you saying I'm not functional? And also, when they ask for such a report, how can you make sure the doctor does not put you so restricted?
Really having active conversations with your doctor when they are filling out that form, discussing and really inputting what you feel your limitations are and what you're capable of. And do know that when you go for the job, the ADA covers the entire process of employment. So even when you're in the application process, in that interview process, you can speak to human resources about what accommodations might look like. There are terms in job development called job carving. So maybe there might be some duties that don't work for an individual, but maybe you can trade that duty with somebody else for something that is more in your wheelhouse. Really, the best thing you can do is just advocate for yourself on both fronts with the doctor and the employer.
How about another round of applause for all three of our panelists? Thank you so much for sharing your stories this morning. Appreciate it. And that's going to conclude this panel discussion.
All right, I am just so pleased to hear from each one of you, and I want to thank everyone for coming today, sharing your time, your insights with us. It's been absolutely incredible. How about one more round of applause? Oh, good. And of course, I'd like to thank once more our generous sponsors. One more time, our presenting sponsors, Corewell Health and UCB. Woohoo! And our community partner, Life Science. SK Life Science, and our network partner, Neurelis. So glad to have you all here today. And one more thing, I want to thank all our participants who have joined us today and taken this time together. Each of you brings so much to us, and we value your feedback. So please take a moment to complete the evaluation. You can find that in your folder, and it has there's also a QR code if you would prefer to do that online. So either way, as you complete that evaluation, please leave it with us. And yeah, thanks. And please drop off your name tag as well. We would appreciate that. So thank you so much for joining us. And we hope we will see you all again on July 13th at the Frederick Myers Garden for our Stroll for Epilepsy. Amazing. Thank you.